All right. Good afternoon, everyone. Thank you for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you for joining us for this webinar regarding strategies for rural healthcare providers in gaining leverage in negotiations with Medicare Advantage plans. LRHA is happy to host this webinar presented by the Health Law Center. The webinar is being recorded. It will be available along with a copy of the slides on the webinar recordings page of our website, and I will drop a direct link to that page in the chat here momentarily. Your line should be automatically muted, and they should remain on mute throughout the presentation. If you have any questions, please feel free to put those into the Q&A box, and we'll address those at the end of the webinar. Also, after the webinar, a survey should automatically open in your internet browser. We do ask that you please complete that survey, as it helps us to continue to improve for future events and identify future education topics. And so with that, I'd like to welcome Michael Schultz. Michael has been representing healthcare providers exclusively since graduating from Tulane School of Law in 1998. As the managing partner of the Health Law Center, he regularly counsels providers on fraud and abuse and regulatory compliance, develops and implements compliance programs, assists with licensure and payment issues, and represents many rural providers with their business and regulatory needs. So thank you so much, Michael, for being here today to present on this topic, and I'll hand it off to you.
All right, it's my pleasure. So this is a topic that is becoming more and more pressing for providers as we go along. So, there's just to manage expectations. It's an area that it seems like the managed care companies have most of the cards, hold most of the cards. So, but there are ways to gain a little leverage and help secure contracts, get in network, get slightly better payment terms. And so we're going to go through those in this presentation. For the overview, the next slide. So I think to give a true context or understanding to our discussion, we're going to briefly talk about the managed care characteristics, in particular their star ratings, and then we'll talk about negotiations, being able to assess what leverage you have, and that can include your access to care, because the managed care companies have access to care requirements that they're supposed to be able to demonstrate, the importance of quality scores and patient satisfaction surveys, and building a stronger relationship with plans. And then part of that too is handling claim audits, reducing claim denials, drafting appeals. We can give you some tips on that. So the next slide. So, it's not a secret that managed care is becoming more and more prevalent throughout the marketplace in Louisiana. 54%, that's over, now we're over half of Louisiana residents are enrolled in a Medicare Advantage plan. That's 6% higher than the national average from 1919 to 1923. Medicare Advantage enrollment has increased by 46% in rural areas. And so what used to be a smaller part of a provider's case mix index or payer mix index, is becoming more and more prevalent all the time. So let's see, next slide. Medicare Advantage, as we all know, is under Part C. Beneficiaries sign up with the plan, and then they can see providers that are in the plan's network. And the whole idea, in theory, is that it's supposed to restrain the growth of healthcare costs, because the managed care organizations are supposed to help control the costs. One of the ways they're supposed to control costs is to better manage patients' care, to coordinate patients' care, to reduce some necessary testing because they're within a provider network, to try to do more preventative care, to reduce patients' conditions becoming more acute, that kind of thing. One thing to keep in mind, though, is that Medicare Advantage plans are required to cover everything that is covered under Medicare Parts A and B. And, you know, as I'm sure you've probably found, their coverage of certain services seems to be at times suspect. I know we've had providers who have complained that they'll get pre-authorization, for instance, like in a psych hospital, they'll get pre-authorization for maybe 4 to 5 day stay, which if you can be treated in 4 to 5 days, you probably don't need to be in the inpatient psych hospital. And then they'll drag their feet for the next 3 or 4 days. And by the time the patient's getting ready to leave and they decide to deny the care, it leaves the hospital holding back. And, you know, we see this with all types of providers. We can go to the next slide. So this is an important thing just to keep in mind when you're looking at how to assess the leverage your particular provider might have. Every provider is going to be different. And we'll go through some of the characteristics that will make your leverage unique. One of the ways that you can gain leverage is by having high quality scores, because the Medicare Advantage plans, part of their star rating is based upon the quality scores of the care that is being provided by the providers that are in their network. So we can go to the next slide. And back, I guess, to complete that point, the Medicare Advantage plan's star rating has a big impact on the amount that they're paid. There's quality bonuses that they'll receive if they're improving quality of care. And so, you know, your ability to impact that is going to help increase your leverage. So looking at what some of the factors are that go into the star rating is looking at the cost of care. So in particular, chronic condition management. To the extent that beneficiaries that are enrolled in the Medicare Advantage plan have their chronic conditions well managed, like diabetes and cardiovascular disease, where you're able to, you know, they're getting the preventative care and routine care that they need to keep their blood pressure under, you know, check, keep their blood sugar in check. It'll help reduce the complications that are going to result from that. And so that'll help reduce the cost of care. Hospital readmissions, and this is more for the, you know, the rural hospitals, critical access hospitals. But it also applies to, that's a traditional readmission statistics. So there's also a statistic that involves the cost of care for 30 days out. So it's the cost of the care in the hospital and the cost of care for 30 days after the hospital. And so they're measured on that. And that, not just readmission, it also includes, you know, avoiding having to go to the urgent care or the ER. It may not be a readmission because they don't actually get admitted, but if they're having an episode because they weren't well managed when they left, then that could drive up the cost of the care. And so that's where, you know, rural health clinics would come into play. FQHCs, physician practices. If post-discharge from a hospital, you know, they're supposed to get some follow-up care and it's timely done, well done, and they're followed, it'll help reduce the likelihood of a readmission, and that'll help the Medicare Advantage score their star ratings. The more you can show and demonstrate that you are, you know, it throughout this, I guess I should back up. It's important to keep statistics on your provider, and how you're interacting with each Medicare Advantage plan's beneficiaries. So going back to this point, if a patient needs to be seen, you know, the order that they need to be seen within 10 days of their discharge to help manage whatever the condition is, and you're not able to see them, that's, you know, that's not great. But if you are able to see them and you can keep track of that data that shows that you consistently get people in within the timeframes, keep track of that data, because that's how you start to gain leverage. Because you can demonstrate to the Medicare Advantage plan that they should be able to have confidence in the fact that their their beneficiaries will be managed. Particularly important if there's multiple provider types in your area that could provide the same services. So if you're a network, it's how you demonstrate that you are a benefit to their overall statistics, which also benefits their bottom line. Patient experience, the survey results, when enrollees are satisfied with the care, interactions with providers, wait times, access, etc., that's more positive data that you should try to keep track of. If you're thinking about, how do we negotiate with the Medicare Advantage plans, and you're just looking at trying to negotiate terms when it's presented to you or when the renewal is presented, and you haven't kept enough data, if you haven't kept sufficient data, then you don't have a lot of the information that you'll need. So one of the important points that we want to emphasize throughout this is as you practice and as you go through your day-to-day, build in processes that'll help you keep track of that information, the helpful information that will impact the Medicare Advantage plan and their star rating and their payment. So, they have independent surveys, these CAP surveys. If you track wait times, access times, if you even keep track of your own patient satisfaction scores, you could develop your own patient survey and keep that information. It's very useful when you go talk to the Medicare Advantage plan about getting in network or renewing your contract, negotiating better terms, etc. And if you can show for that plan, if 100% of the beneficiaries in your practice or seen at your hospital or in the clinic or whatever it is, are routinely vaccinated, it'll help show that you're helping manage the overall cost of care for their beneficiaries. Plan responsiveness. So one of the things they are required to show is they're supposed to try to show areas of improvement. And so how you can help them, wherever you can help them reduce patient complaints, increase vaccination rates, reduce wait times, etc. It all comes down to those statistics that you should keep throughout the year. Okay, next slide. So the value of these scores is, better patient clinical outcomes, patient satisfaction, etc. But if you're able to show that even if it's not with this plan, but you can show statistics on how your overall wait times are, etc., as you're trying to get into the plan, then it'll make you more attractive to that plan. And if you don't have access to care or other issues that you can use, that is an important tool. You can go to the next slide. All right. So the question is, when you're getting ready to negotiate with a managed care organization, what leverage do you have? And how can I use my leverage? You can go to the next slide. Sometimes it feels like, they're basically giving you an offer that you can't refuse. It's they often say, we don't negotiate these terms. And so it feels a little bit like you're dealing with the Godfather. Next slide. Yeah. I was originally going to joke that no, you don't have any negotiating power. So that was the end of the presentation. Thank you, everybody. And it can feel that way, but that's why we're doing this presentation. You can go to the next slide. So, like I was saying before, you need to look and look at your cost of care per practitioner, the cost of the drugs per practitioner, because that goes into the overall statistics. Managing the chronic care conditions like we discussed before, your own quality scores, and patient satisfaction. So, even if you don't have a formal survey process, which they aren't that difficult, you can set some up online, or you can flag a certain percentage of patients. You can select them at random or whatever. The more you can demonstrate that it's a true random sample, it's more persuasive. But even if you're not going to do that, gathering testimonials from patients, from their families, is helpful. Another piece of information to consider too is when you consider the fact that this is part of a network that the Medicare Advantage plan has that is supposed to be comprehensive for their beneficiaries. The interaction between providers is important. And so if you can have positive feedback from other providers in that plan's network, that's also very helpful. Because it'll help show coordination of care, and which is part of the whole purpose of having Medicare Advantage plans in the first place. There are national quality programs. There's quality reporting information, there's care compare, there's Pepper reports, independent ratings, etc. But you should be aware of also, yeah, this is another point. Even if it's not a provider in there, when you're looking to see, do I want to be in network with this Medicare Advantage plan, you should look at what other providers that may be referral sources or providers that you would send your patients to. In other words, think of the coordination aspect of the care. And if very few people or very few providers are in network with that provider, may not be the one you want to go after. Or, you may decide that you're willing to do it, but it's going to require, you may have enough leverage to get a better payment schedule rate out of it because they need people in your area. But looking at what your referral sources or places that you would send patients to either post-acute or in some other coordination, looking at their participation in networks is going to help give you an idea of the market and which plans are more important, which plans you're willing to walk away from if you need to, etc. And then another thing is if you can offer a service that is otherwise not in the market, like say you're a rural hospital, critical access hospital, or even a rural health clinic, and cardiology services are sparse. You don't have an invasive cardiologist in the area. If you're able to get an invasive cardiologist to come to your hospital or to see patients in your clinic 1 day a week, 2 days a month, something like that, it makes your practice, it increases your leverage with the Medicare Advantage plans because they're required to show access to care. And the more you can show that you can fill a gap in their accessibility is going to increase your leverage. Next slide. Determining your position. As I've been saying this whole time, preparation is the key. You can't start to put this stuff, put the material together. Well, you shouldn't start putting this material together as you start to approach your negotiations. You should be gathering this throughout the year. And I don't know if what I'm saying seems overwhelming in terms of the amount of information, but any information that you gather is going to be better than nothing. So you look at the resources that you have, personnel that you would have available to help, and gather what you can. But focusing on what is going to be how to show your advantage to the MA plan, because then it's going to just increase your leverage. So you need to know what your payer mix is. What percentage of your business does this particular MA plan represent? What do the competing providers offer? Are they in the same network? Are they in other networks? And then looking at your referral sources, survey them, find out which plans they're in. It may show you an opportunity to get a network with that particular plan because it's increasing its market share, so that would make it more important. Or you may have a service they don't have. It's how you identify those things. And you may find that if the plan is pervasive in the market, you may be willing to take a little bit less to make sure that you are in that with that plan, because without being in the plan, you may be cutting yourself off from not only referral sources with regard to that particular MA plan, but they may develop other referral patterns as they're trying to coordinate care, and you'd lose out on other beneficiaries from other plans that you may have better payment rates with. So you have to look at how that factors into your bottom line. Let's see. For hospitals are required, when you're looking at payment rates, hospitals are required to publish their negotiated rates on their websites under what's known as the hospital price transparency rules. So that's a good source of data on what your competitors are receiving under their negotiated rates from other from other payers, including Medicare Advantage plans. But the important thing too is, just like when you're going to negotiate the price of a car or anything else, the more you understand your position in the market, the more you understand your particular need to be in network with this plan or to remain in network with this plan, the better you are prepared to be able to walk if it's just not advantageous to accept the payment terms that they're offering. But having that information will give you the access to what you need to make that decision. The next slide. And you need to know your goals. You've dealt with Medicare Advantage plans. You know what your payment rates are. You know what your cost structures are. Hopefully you would know their pervasiveness in the market. And so you have to look at, what are you willing to accept and what are you willing to not accept? What's your bottom line? What is a term or terms that if you can't get or can't improve, that you're willing just to walk away from? And then you need to know what you want, what your target is, what your goal is. And so then from there, you figure out what your ask is. Your ask is going to depend on the leverage that you have. If you're willing to accept, I don't know, just for illustrative purposes, let's just say a payment rate of $100, right? That's what your goal is. Your bottom line is you can't go below 75. Well, you're not going to ask for 100. You ask for 125, 120, and let them come back against you. But it also depends on the circumstances. If they're seeking you out, you've got much more leverage. It shows that they've done their data analysis and they have access problems, and so they're looking for providers to fill it. And so it all goes in. I wish there was, I'm sure this all sounds very vague, in terms of how does this apply to me? But it really comes down to your individual circumstances. And that's, without knowing more about a particular situation, I think that's as specific as we can get. You have to decide what matters to you, which network you need to be in network with, what terms you're willing to accept. And then you ask for more. All right, next slide. So the refrain that you get, I'm sure you've received it, it's what we hear all the time, is, we don't negotiate those terms. We don't negotiate the payment rate. We don't we've determined the payment rate based upon market statistics. The answer is always no if you don't ask for it, if you don't try to negotiate it. It's always going to be no. They're not going to just out of the goodness of their heart come back and say, I know we offered you X, but we'd like to pay you more. So, don't be afraid to negotiate. What can you negotiate? Well, payment related provisions. You need to make sure that the way that the payments are explained are clear, so you'll know what you're getting paid. Avoid language in the payment terms that involves the lesser of, usually the lesser of a certain rate or cost. And it's if you become more efficient, you shouldn't get penalized for that. It's just a way for them to try to cap it. So remove those terms, and you usually can. And then rather than trying to, we see this where providers there'll be auto renewal clauses in a contract, and it'll just continue for 3, 4, 5 years. And you start to assess it and you realize, this Medicare Advantage plan is way below what the other Medicare Advantage plans are paying, what other payers are paying, and we're losing money on these patients. And so then you try to negotiate a 8-10% increase. It's a lot harder to negotiate an 8 to 10% increase in 1 year than it is to build in incremental increases that go into effect upon each renewal. So you can rate it at 2 to 3% increases, or you can tie it to an index like CPI. It's hard, it's dangerous. And sometimes people will want to tie it to the Medicare rates. It's less of a concern with primary care, I think. The primary care payment rates don't usually go down so much, but they can. And you don't want to, so if you tie it to the Medicare payment rate, you're subject to Medicare's priorities may be changing and reimbursement rates falling in one provider type or for one service type. And then having that automatically affect your own payment rate in your contract. So it's better to tie it to a CPI index if you need to, or to request just a steady 2-3% increase each year. But like I said, don't let it go on. Don't let the renewal clauses continue to go into effect, and then you realize that you're behind the curve because it's hard to make up the difference. You should try to put in the ability to negotiate or the right to terminate the contract if Medicare Advantage, if that particular plan's policies, a lot of times they'll have policies that are built into the contract terms. And if the policies change that negatively affect, how your relationship with the Medicare Advantage plan, you should be able to terminate the agreement. And having that clause in there will help safeguard you against those. Either you can terminate the contract, or knowing that you can terminate the contract, they may be willing to not have those changes apply to you. For instance, they decide that they're going to reduce payment on something, or they're not going to cover certain drugs or whatever it is. If it impacts you, and you have the ability to terminate, it helps build in leverage as you go through, again, as you're living under the contract. Claim submission period, you should try to put in very specific timelines and extend them out as best you can. But if your provider uses a third-party billing company, make sure that you discuss the timing with your third-party billing company, and make sure that any difficulties that they have aren't going to start to impact your ability to submit claims. And so while you can't, there's limited negotiating you may be able to do with the Medicare Advantage plan, other than maybe push the dates out from 60 to maybe 90 days or 120 days. What you can do is with your billing company, if billing is late that you can't submit claims due to some fault of the billing company, you can have an indemnity clause that requires the billing company to indemnify you for the loss of income due to their delays. And then make sure you're clear on when they have to pay, how long the Medicare Advantage plan has to pay you. And I keep saying Medicare Advantage. The principles under this would also apply to the Medicaid MCOs, you know, Healthy Blue, Louisiana Healthcare Connections, etc. All right, we can go to the next slide. So one of the big bugaboos, as we mentioned in the beginning, is prior authorization. In your agreements, try to make sure that everybody's on the same page and is clearly expressed, and that everybody understands the requirements for obtaining prior authorization, the documentation that will be required to obtain the prior authorization, so that they, you know, if the patient, say, in your hospital and you're seeking a renewal of their authorization for continued days, you should have in there a clear process and what documentation is needed, so they can't keep asking you for documentation to drag it out. And have just define specific timeframes in which they're required to respond. I know there's been some recent final rules from CMS on trying to implement some protections for providers under the prior authorization, process. But it still comes down to making sure that it's in your contract and it's clearly spelled out. Audits, you can try to negotiate the number of audits. If not so much the number of audits, what you can try to negotiate is that if you perform well under an audit, below, say, an error rate of 10% or an error rate of 5% or something, the Track, Probe, and Educate program that CMS runs for traditional Medicare claims, if you're under 10%, then you get a year of break. You won't be under the Track, Probe, and Educate audit program, I think, for up to a year. So you can negotiate that, where if they perform a claims audit and you perform well, then you should get a break, and you can try to negotiate that into the contract. And make sure you're aware of the appeal timeframes and the appeal process, where to send the appeals, etc. The next slide. You can go to the next slide. Oh, here we go. Okay, so now you have one. Let's say you're in the contract. What do you do? Well, depending on your resources, again, this is all dependent upon the personnel that you have. If you're sole practitioner, you may not have somebody that is going to be able to dedicate a good deal of time to this. But try to have a point person so that things don't fall through the cracks. Even if it's something that they, you assign them to do 5 hours a week or 5 hours a month, whatever that comes down to. Have one person be the primary staff member, coordinating communications with the Medicare Advantage plan, coordinating the gathering of the documentation that we've been speaking about, the statistics, the quality surveys, the quality of care, the patient satisfaction, all those things. One person should be point, so that it doesn't, things don't fall through the cracks. Make sure that when they save stuff, when they save information, when they save communication, anytime they talk to somebody at the Medicare Advantage plan, this goes for traditional Medicare, anytime they talk to somebody at Novitas or one of the other MACs, anytime they talk to somebody at the MCOs, anytime they talk to somebody at LDH, they should always keep a log of the conversations, who they spoke with, time they spoke to them, and what was discussed, because that comes in very handy. Now, most of the time, they're going to give you a number that will be the reference of that conversation, so that if you call back and you give them the number, they can actually pull up the actual conversation. Those things are all important. So have somebody who is in charge of keeping track of all that information. Then to manage your relationship, know when the contract's going to expire, what required notices there are for any modifications. If the agreement is auto renewed and it's already been renewed under the terms, your leverage starts to go down, right? So you have to make sure that you schedule the negotiations ahead of time so you can have that discussion. And throughout the year, as trends happen or as difficulties happen, try to continually assess your relationship with this particular MA plan. It may be that they have great payment terms, but they continually deny payments, or they require an excessive amount of time in dealing with them to get things resolved. And if they're not a big part of your payer mix, you may decide it's not worth it. Or you may decide that, while they have a particularly good payment schedule, it's still not worth it, so you want more. But knowing that information is going to give you that opportunity, that the tools that you need to make that decision. And so, like we were saying before, regularly process or implement processes to update, acquire, document, preserve your provider data, cost, your payer mix, quality metrics, your payment, your patient satisfaction, and your interaction with referral sources, or either practitioners who refer to you or that you refer out, or where there's just a common you're often coordinating care with the patient with that particular provider. Be aware of what's happening with them in terms of which plans they're in or out of network with. But you have to, like I was saying, you have to keep track of that throughout the year. And so having a process where you're gathering that information just as a matter of routine is incredibly useful. And then it'll help avoid having to scramble to gather the information at the end. And then identify areas of possible improvement. Remember back when we were talking about the star rating, the Medicare Advantage plan gets assessed for their quality scores of the beneficiaries that are in their plan, and they're also assessed for improvements. So if you are able to show, let's say you have a low vaccination rate, it may be that maybe you could get some patient educational materials that you could hand out, be willing to discuss with the patients, overcome whatever the resistance is to vaccinations, and increase your vaccination scores. Then you demonstrate that to the MA plan, and it goes into their statistics. It shows that you're functioning in a way that helps them meet their goals, and that's where your leverage comes from. If you see an opportunity to offer a service that's not available in the market, in the area, within 30 miles, and it's feasible, then that might be a priority for you to develop. Find the interventional cardiologist, find the nephrologist, or find whoever it is that you think would help plug that access gap in your area, and then that's how you gain leverage on that plan. Next slide. And so one of the big things, you provide the care, you see the patient, you assess their needs, you provide the care, you submit the payment, and the payment gets denied, or you submit the payment and it gets paid, and then later they come back and do an audit and they take the money back. It's just no good for anybody. You know, next slide. So we wanted just to provide a couple quick pieces of guidance on how to deal with these claims audits. And this applies to any audit. Private insurance, traditional Medicare, Medicaid, MCOs, managed care, etc. Your most valuable asset are your medical records. I mean, it is what it is. It's why people continue to harp on the quality of the medical records. If it's not documented, it didn't happen. But just documenting it isn't enough. You have to make sure that it's complete, that it's enough to be able to explain the need for the care that was provided, coordination of the care, the follow-up care that's recommended, and then that eventually happens. You need to write it and have your staff write it in a way that someone who's never seen the patient, someone who has no idea what happens every day in your practice setting, can look at those records 5 years from now and understand what happened and see that the criteria were met, see that it was medically necessary, right? So, and you can't miss deadlines. If something is required within 24 hours, make sure it gets done within 24 hours. If it needs to be signed, make sure it's signed. But there are ways to fix missing signatures. The more contemporaneous you do it by reviewing your charts and making sure that it's done, the better off you are. But it should fully, like I said, it should document the medical necessity, should document the patient's response. Just as an example, if we're talking about, I mean, this probably doesn't, it's not particularly relevant to y'all, but it's a good example of what to put in. So in a group setting, for a group psychiatric care, if the therapist just writes, the patient did well today. How did they do well? What do you mean by that? And what did they do that made you reach that conclusion, right? Or if it's therapy, if physical therapy, the patient is progressing toward their treatment goals, how? Are they able to walk 15 feet, 20 feet? I mean, what are we talking about? And which goal does it relate back to? If it's, the patient's blood pressure is under control, well, what are the goals of keeping, how does it relate to the goal that the patient has or that you have for the patient? How closely has it been monitored? You have to look at the bigger picture when you're writing your notes, because that's the way to avoid claim denials in the first place. You can go to the next slide. So now you get charts that are audited. This one is particularly important. Every chart that you send in should be organized in exactly the same order. Depending on where you put the assessment or the treatment notes or the nurse's notes or however, whatever it is that you have in that claim. Lab results, they should all be in a uniform order. Doesn't matter so much which order it's in, it just needs to be uniform. And then you need to have a table of contents that highlights the key documents that are needed for payment. So being familiar with the payment conditions, if you're required to have evidence of a lower level of care that didn't resolve the issue, maybe it's some sort of interventional pain issue, and you tried non-interventional means and they didn't work. You need to document that, and you need to highlight where those key documents are in the outline, in the table of contents, because what your goal is to try to make the reviewer's job as easy as possible. The easier you make it for them, the better off you are, because the auditors, like it or not, they're not board certified surgeons or whomever willing to look through the entire case file. They have 3 to 4 or 5 minutes, and they're going to look through it. And we see denial after denial after denial, saying that documentation is missing when it was in the file, they just didn't see it. So avoid that, cut it off, head them off at the pass by walking them through, handhold them, show them where all the important documentation is in your table of contents. And if you really want to go above, you can even provide a cover letter that explains, you know, where the documents are. But that seems to, in our experience, that probably the time that would take isn't usually worth it. The table of contents will do the job, but you got to make sure you do it. And then also in the request, if they don't specifically ask for a type of document, but it's still relevant to the care provided, provide it. I had this is a horror story which helps drive this point home. There was a doctor who a cardiologist who started to do a lot of vein ablation, and he developed certain techniques, and a lot of other cardiologists would send their vein ablations patients to him. So he started doing basically vein ablation, and he got a medical records request. It did not request ultrasounds specifically. It listed a bunch of medical record, parts of the medical record, and then it said anything else that's relevant to the claim. So they didn't send in the ultrasounds. The next time they heard anything about it was when the FBI was at their door asking, taking records. And it turned out that they were there because the government thought that the doctor was providing vein ablation without first doing an ultrasound, which is required. And he was also billing for the ultrasound. And they thought it hadn't been done because they didn't send the record in. So, don't just look at the record request as a checklist. Look at it as the minimum documents you need to send in, but send in everything that's relevant. Okay, next slide. So heaven forbid, let's say the claim is denied. When you are appealing, try to address the reasons that they are denying the claim, though that sometimes can be difficult because they don't always articulate it. A lot of times the denial will simply just be a recitation of the clinical picture of the patient, and then they'll say something that there wasn't sufficient documentation of the physician's involvement or something. But it's hard to know what that means. So you refer back to the actual conditions of payment and try to identify what is it they're talking about. If they mention physician involvement, well, then look in the payment rules for physician involvement for that particular service, see what is required, and explain how you met that criteria or met that requirement. Then when you submit the appeal, bait stamp all the pages. Bait stamp is in the Adobe PDF, you can go in and assign a page number that'll be uniform throughout the entire attachment of the medical record. So it's easy to reference back. So in your appeal, you can tell them which page number to look at specifically, rather than giving them a date of a nurse's note or something and having them have to thumb through, then it can go right to it. And so, address the reason specifically, discuss how it was comprehensive or how you met the criteria, etc. And that's your appeal. But sometimes you have to read into it as to why they are denied by looking back at the payment conditions themselves, because they don't always articulate the reasons for denial. All right, next one. And so this is something that I wanted to really stress. Your post-claims audits information, right? And this is incredibly useful for a number of reasons. One, if it's identifying something that you need to improve, this is a great source of information because it may be they're right. It may be that the doctor didn't write a complete note, or they didn't see the patient in time, or that a critical lab wasn't followed up with, or whatever the situation is. Or maybe there were just the documentation, the doctor thinks that the documentation is such that, it was a level 4 visit when it really wasn't. Not only did he not spend time, but on the substantive method of determining your level of visit, he didn't explain why it was a comprehensive, um, uh, you know, medical problem and the decision making that he had to go through, et cetera, et cetera. And so if you need to improve your documentation because it just isn't there, this is a great way to identify those areas of improvement. If it's timeliness, it'll identify the need to implement a process to make sure that someone's checking to make sure it's timely, et cetera. If it's not complete, signatures, et cetera. But it should also be incorporated in your compliance assessments. Providers have different levels of compliance programs. Everybody should have a compliance program. There's not one size fits all. It's all dependent upon your resources, but having something that you actually do is better than nothing because it shows you're doing what you can, that you're acting in good faith, and it'll help you avoid fraud and abuse claims, fraud and abuse allegations. Because if it's if the government wants to show that you violated the False Claims Act, which is knowingly and willfully submitting a claim for payment that you knew was not appropriate, then they have to show knowledge. And so having claim audit results where you do really well, or claim audit results that you did poorly with but addressed, will go a long way in undermining that. And also performing well in your audits, having that data at your disposal will help you when you negotiate with care plans because you can show that your quality provider, you document your materials, your interventions, et cetera. And so I'm realizing that I've talked too long, so we don't have that much time, but I'll turn it over to any questions we got.
Thanks, Michael. Yeah, if anyone has any questions, please feel free to put those in the Q&A box, and we will read those out and get those addressed. So I'll give just a minute. Go ahead, Michael.
And if not, if they want to submit them, I'll take them and send you some initial responses back too, since we're kind of look back on time.
Yeah, if you again, if you have questions, you want to put them in the Q&A box now, we'll go ahead and read those out. But if you would rather send them separately or you think of some later, anything like that, feel free to email those to me. And or you can email them to Michael and then we'll get those sent out to you. We'll get the answers out to everybody. If any additional questions come up as you review the slide deck.
I mean, if you're like me, you'll think of your question in 5-10 minutes from now. So if you get a question, email it to Danae and she'll get it to me.
Yeah, so we did have one come in. Has there been any reported or observed changes in behavior since the new guidance from CMS came out earlier this year, specifically the post-acute care guidance?
Post-acute care guidance in what particular?
The CMS, let's see, new guidance specifically on post-acute care from CMS came out earlier this year.
I guess I need to know more. I mean, there's patient choice updates. There's I guess I need to know more about what the question is. And also in terms of trends, I don't know if I would see it. We usually deal with problems, and so it takes a while for the problems to manifest themselves.
Yeah, so he said clarifying specifically how MA plans can review, or how I'm assuming MA plans can review for medical necessity.
Are you talking about if they do a pre-authorization, can they come back and deny for medical necessity? They're not supposed to do that. And there was some guidance earlier this year that limited that. But I haven't seen the results of that.
Okay. Yeah, and that's Blake. He's going to email that question to me, so we'll get that. We'll get more detail on that question.
Perfect.
When it comes to prior authorization, do you see providers successfully negotiate to reduce the number of services that require prior authorization? Or do you largely see the negotiation being around obtaining transparency around prior auth requirements and timeframes?
It's usually around transparency, but I know we've had some psych hospitals that were able to take their uncompensated days, meaning days that they couldn't get uh, authorized. And it was usually because they were in the hospital already. That's why that example was in my head earlier. They were able to reduce the number of unauthorized days by no longer, they no longer accepted just the 4 to 5 day stay. They said that it's not medically reasonable to expect somebody to be treated for in an inpatient psych hospital in 4 to 5 days. So that's not enough. And they had enough market share leverage that they were able to get. I think the initial authorization got moved up to 10 days.
All right, I don't see any other open questions. We'll give it just another few seconds. I realize we're at time. Again, if you have additional questions, feel free to email those to Michael or myself, and we'll get the answers out to folks. I did put the post survey link in the chat, so please do take that. That helps us to improve our sessions and identify topics for future sessions. And if we can be of any assistance, please always feel free to reach out to us. Any final comments before we wrap up for today?
No, that's it.
All right. And then everyone will get an email. The recording and the slides will be on our website within the next couple of days. That link's also in the chat, and then you'll also get that link via email. So again, thanks everyone for being here today, and have a wonderful afternoon.
All right, thank you.